Welcome to End of Life University on YouTube. Today I'm sharing with you a conversation from the archives. So this is audio only. Sorry, no video, because back in the day I didn't have that capability. But this conversation was with Dr. Bob Uslander, who's a hospice and palliative care physician in San Diego, California. And we talk all about his new model for a practice really of caring for end of life patients and his involvement in medical aid in dying as well. So I think you'll really enjoy this conversation. If you haven't already, make sure you subscribe to the channel down below and be sure and subscribe and leave a rating and review for the podcast wherever you happen to listen. Also, if you're inclined to help out financially, just a little bit, a tiny contribution, you can go to eoluniversity.com/support. You'll find 3 different ways you can make a donation that will make a big difference and help keep this channel on the air. So thanks in advance if you choose to do that. And now we'll move on with my conversation with Dr. Bob Uslander. Hello and welcome to End of Life University. I'm your host, Dr. Karen Wyatt, and I'm so glad that you're joining me today for this conversation, which I think is extremely important and something I've been wanting to talk about for quite a while now. My guest today is Dr. Bob Uslander, and I'll tell you just a little bit about Dr. Bob. He is trained as an emergency medicine physician and has practiced for more than 25 years, and he currently works as a concierge physician, leading a team of holistic practitioners serving the elderly, those experiencing complex illness and end of life. So, Dr. Bob, I want to thank you so much for joining me today.
Oh, thanks, Karen. I appreciate it. It's nice to be here with you.
Yes, ever since I had the opportunity to meet you, I've wanted, first of all, for myself to learn more about the work you do, but also to share it with this audience. So I've really been looking forward to this for quite a while. And I want to talk a lot about your concierge practice, but first I was hoping you'd just tell us a little bit of your story and how you got interested in helping patients at the end of life.
Sure. No, I'd be happy to. And I think, you and I we've kind of followed similar guidance, and our paths are kind of aligned in where we find our most impact and the need out there. So I know that we're kind of birds of a feather. So it's really nice for me to be able to share with you. So yeah, I know it's a little bit odd to think about an emergency physician now making this complete transition and working with people primarily at end of life, and it wasn't really a path that I could have anticipated or planned out, but life is kind of like that. Mm-hmm. Yeah, so I was doing emergency medicine, and my choice to do emergency medicine as a career came partly from when I was in medical school. I had a mentor who was an ER doc, and I got to go in and spend a lot of time sort of observing and being part of that world, and I got drawn into it. I remember in medical school there was a brief period where I actually was thinking that I wanted to go in and work more with patients with cancer and in that realm, but that kind of got squashed, and I continued down the path of being an ER doc. And it was great. It was a great career. I got a lot of great training and great experience. I traveled and worked in different locations and really felt like I was doing great work. About 10 years into my practice, so this was in 2001, I had a friend. I was living in a small town in Northern California, and I had a close friend who developed melanoma, and it spread, and ultimately he died from it. And he was a young guy. He was only 32, and I got to help take care of him because he didn't have a primary doctor, and as he got sicker and needed more support, we brought in the local hospice team. And I had really never had any exposure to hospice before that. As an ER doc, the only time any hospice patients come in the ER is when kind of it kind of feels like someone didn't do their job right, mm-hmm. or So I really didn't know much about how hospice operated or what the the true impact was, but through taking care of my friend Darren in his last months of life and at the very end, I just saw a whole new way of caring for people, like an entirely new model that really blew me away. And so I got really drawn into the world, the hospice world, and through that experience. And even though I continued doing emergency medicine, I knew that there was kind of a seed that was planted. And a couple years later, I started a house call practice for homebound seniors. And then I started a home care, private, non-medical home care company to help fill more of the needs for those people in that community. And then, fast forward in 2011, I moved to San Diego and knew that I was looking for some sort of transition. Emergency medicine at that point had gotten very stressful, and I was ready for a change. And I just had a series of encounters and sort of messages, I think, from the universe that made it very clear that I was really called to work with people at end of life. I had this like epiphany one evening about this, and then the next day I met a nurse who does hospice care, and one thing led to another, and I became the medical director for a palliative care program. And so I got very immersed in palliative care and hospice, and through that experience I got to see all of the great benefits of palliative care and hospice, and I also got exposed to a lot of the gaps, a lot of the problems that still existed in the care of these folks. So 2 years ago, I started my own practice to kind of wrap around and provide a high level of support and care with a team of kind of nurses and nurse practitioners and holistic therapists to do something really different and create a whole new sort of model of care for people as they're approaching the end of life. And that's how integrated MD care was born.
And that you're right. This is a whole new model, which is what excites me so much. This idea of a concierge practice and the way you're operating it. And as you said, because there are gaps in the way hospice care and palliative care are offered right now, I think it's so important for us to look at new models and really be creative here about how we can help fill those gaps. So maybe you could explain to our listeners a little bit more about how your concierge practice works, because some of them might not be familiar with that concept.
Sure. Yeah, I'd be happy to. And I'll share that it would be actually really nice. I would be very happy if the need for my practice didn't exist, right? If people were able to get their needs met through their traditional channels and through their insurance or their Medicare and the healthcare system was really meeting those needs well, then there wouldn't be a need for this practice, and I'd find something else to do. But the fact is, there as people's, and you know this because you've been within the system, but many people don't know about these gaps, and they're not aware of the areas where they end up having great challenges until they're like right in the middle of it, and at that point it's overwhelming and kind of terrifying to be thinking about all the things that might need to happen to get out of that. And some of the gaps I'm referring to are things like when somebody is diagnosed with a serious illness, whether it's cancer or heart disease or Parkinson's disease, it starts this series of medical appointments and tests and specialists and potentially the need for additional services in the home, which for the most part are placed on the patient or their family to try to coordinate and figure it all out. And most people don't have that expertise, and they end up struggling under the weight of all of that. People go into the hospital, and then when which is a huge issue all by itself, having to go through that hospitalization and system. But then when they're looking at the discharge from the hospital, a whole new set of needs arise and challenges, and then people are making recommendations for either home health or hospice or home care, and it just mounts. And most people don't have nearly enough information, education, or support to be able to do that well and without it being terribly challenging.
Mm-hmm.
So my practice basically is to try to identify those areas where people are struggling the most and provide support. So we may get patients who have been in the hospital and have been treated for, let's just use cancer as an example, and they've had complications, and now they're going to be discharged, but they don't know, so they're being pushed to go on hospice because the treatments are really not helping, and they're struggling through the side effects and the symptoms, but they don't want to go on hospice because that word hospice is kind of like a death sentence for people, and they don't really understand what they have to give up and what the benefits are. So one of the areas where we really fit in is to be a bridge for
Mm-hmm.
people who have significant struggles and they don't know what services they need and who's going to ultimately support them. So we can go in and meet with the patient, the family. We help arrange the different services that they will need when they go home, whether it's home health or hospice or caregivers or physical therapy, whatever. And we can provide the medical care in their homes. We have nurses who can go out and provide support, nurse practitioner, and we're available 24/7 to manage and deal with any changes that come up in a sensible, responsive way. That's kind of on one end of the spectrum. On the other end, we just have we have patients who are in their 80s, 90s, or even over 100, who are living at home with a spouse or sometimes with caregivers, and their families either don't live in the area or they're really busy, and so we can provide this in-home support so that they don't have to go out to the doctor's offices, or they don't have to wonder what to do if they develop a cough or some change that usually ends up going to the ER and potentially a unnecessary hospitalization and a whole bunch of stressful events. So we provide just a high level of support and care for people at different stages. I think our real differentiator, or the sweet spot, the area where we really bring the most value, is for those people who are in their last days or weeks of life, to really provide the kind of support that people want and bring the physician back into the equation, which when people get on hospice, they usually lose their physician, and we really support the families in a very deep way. That's a lot of the focus, is really supporting the families to make the right decisions.
So it sounds like I love that you use the word a bridge, that you're serving to just meet the needs of the patient and their family in the moment, whatever those are. And it's no longer, so we so often see patients who, as you said, who are not ready to choose hospice yet. Therefore, they're not getting any of the services that hospice might provide them because they feel too rushed and they just can't go there in the moment, and you're able to step in, provide guidance and navigation and care while they're in the middle of this very confusing time and trying to understand what's going to happen next or what they need to do next. So it sounds like you make home visits to patients. Do you also have a clinic and an office where you see patients as well?
So I have an office, and we have a little exam area in there. Very few of my patients come into the office. Most of them are seen at home. I'll use the office sometimes to have family consultations, to bring people in so we can kind of talk about the situation in an environment that's away from the home if they prefer that. We do a little bit of primary care. I have a couple of other physicians who work with me and do primary care on a direct primary care basis, so kind of removing the insurance and the intermediaries. They pay a set fee per month, and we just take care of them, whatever they need. But most of it's at home, which is really what I prefer, and I think the patients and families prefer as well.
Oh, definitely, because it's just such a struggle, when you have a bedbound patient to try to get them up and dressed and out the door to
Mhm.
go to an office visit and sit in the waiting room. It's just really impossible, so, many times. So
I
that's
experienced that, back in my 20s. I experienced that with my grandmother, who was in Chicago, and I my mom was an only child and was the one who was helping to take care of everything. And as she became more dependent, my grandmother, I remember that her doctor was probably about 25 minutes away by car, and each time that she had to go in, and it happened more and more as things changed for her, it was like an all-day affair, like getting her ready. She would start getting really anxious the day before or a couple of days before about the whole process, and then getting her ready, took hours. Getting her there, getting her into the waiting room where she'd end up sitting in the waiting room for 15, 20 minutes or more. The time with the physician was brief. Often nothing happened of substance, because a lot of it happens over the phone, and then reverse the process and go back, and it would take her a couple of days to recuperate from the event. So that it really made it very personal for me to think about what we can do to reduce those challenges and struggles, and then someone has to take a day off of work, and we need to be providing more sensitive, more appropriate care for people. So this is one way to do that.
Mm-hmm. It's interesting because the idea of patient-centered care, it's such a buzzword now in the medical system, and yet for what we call patient-centered is still that same model. The patient's
Yeah.
the one who has to
Yep.
be inconvenienced and come into the office and sit in the waiting room. And so, what you are providing truly is patient-centered. And the patient's medical home is their own home. That's where they get their
Yeah.
care, and it's perfect. That's really a beautiful model. So tell me a
There's a
little bit more about the services. I know that you have a team, right? A team of people
mhm.
that work with you, similar to the hospice team approach. And what other services do you provide?
Well, so if somebody is calls to get information, right? Maybe we get patients. A lot of it's word of mouth. There may be like a hospitalist or a palliative care physician or a case manager in the hospital may be interacting with a patient and family and realize that they're looking for a different level of support. Typically, we will have a conversation with the family member. It's usually the family members who are kind of finding the additional services, and we just explore what their needs are, what the situation is, what their current support team looks like, and what they're missing. We talk about those gaps, and then that gives us a sense of whether I think we can meet their expectations. And sometimes they don't even know what's possible because there aren't practices like mine around, so no one's kind of expecting it. So I have to sometimes help people see what is possible, and assume if they're open to having us come out and do an assessment, or a lot of times they're just ready and they want us to start providing care. Then I go out with usually one of my nurses. I have a couple of RNs, and I have a nurse practitioner who works with me, and a social worker, and a couple of us will go out and meet the patient and family and do our assessment, and then come back and give them kind of a proposal with this is a plan of care which we think makes sense and will meet your needs, and this is what it looks like from a financial standpoint. And so we have a monthly fee. It's kind of like a retainer, and it will help. We estimate how many visits we'll make from the physician, the nurse standpoint, and then what kind of engagement it's likely to require in between. And so, and our fees, they could be several $100s a month for the basic, and then it could be several $1,000s a month for people who really need a more intensive level of support. And so we have, our nurse will go out and make visits as needed, nurse practitioner, myself, and the rest of the team consists of people like massage therapists, acupuncturists, music therapists, an expressive arts therapist, physical therapy, an exercise kind of guru who also does yoga and mindfulness training, a nutrition expert. I have a nurse that is very well versed in cannabis medicine, who can do assessments and make recommendations and facilitate patients getting appropriate cannabis products, and then like marriage family therapists. We have all those people are, aside from the nurse and the nurse practitioner, the social worker, the therapists are all sort of independent contractors who have their own businesses, but we have found the best of the best, and we facilitate their visits and do centralized scheduling and centralized billing. So the family only has to really deal with us. They get the benefit of all of these additional therapies when they're open to them, but it's very streamlined and not overwhelming to have this incredible team that's all focused on improving well-being and promoting healing or comforting, whatever that, wherever the patient's needs are.
That's
so
wonderful.
It's beautiful. It's really,
yeah.
I mean, we have story after story of people who are, some get better. Some people are on hospice and everyone is giving them a month or two to live, and they start getting all of this treatment and this attention and these connections with these beautiful beings, and all of a sudden they start feeling better and things turn around. And then of course we have people who are dying, and we're able to provide much more comfort for the patient and also for the family by making some of these additional therapies available to them. One of the things that has really become so clear for me in doing all of this is that the patient's needs are obviously paramount, and making the patient comfortable and addressing their needs, helping work through their fears, and that's all very critical. But the piece that I think we've been missing for a long time is taking care of the family, because you get these patients who are struggling and having these challenging circumstances in and out of the hospital, or just in their last phase of life, and their families, their children, their spouses, their parents, whoever comprises the family, are usually needing a lot more support than anyone has ever been able to give them. Mm-hmm. And they're the ones who at 2 a.m. are going to make the decision to go to the emergency room or not. They're the ones who are going to weigh in on whether to try another course of chemotherapy, even though the first several only made things worse. They're the ones who are overwhelmed and hurting. And so my model is able to provide care and support for the families equally to the patients. And by doing that, everybody is able to approach the whole situation with more understanding and less fear, and just knowing that they have someone that they can text or call or email with questions. It's been a huge awakening and awareness for me to realize that's a piece that we've been missing for a long time, and we need to focus more on caring for those families.
That's so true. You're so right about that, because the families are carrying the entire burden of the caregiving, and it can be overwhelming, and also because they've never done it before, so they're in a totally new place, and definitely need a lot of guidance and support as they're going through that. So, Bob,
Yeah,
I was wondering, do you ever work side by side with hospice or refer patients to a hospice in the area?
absolutely. Um, I actually get referrals from hospice agencies for a couple of different reasons. One, I think, as we'll be talking about in a bit, we get referrals for patients who are looking for support for aid in dying.
Hmm.
Um, we get referrals from hospice agencies when patients are being discharged from hospice for extended prognosis if they don't if they improve or if they stabilize. Um, they've been receiving more care than the traditional model, and sometimes hospices will help people continue to get that higher level of care by referring them to us. Um, and then there are hospices that the nurse or social worker just identify that the family needs more support, and because most of the time they don't have a direct relationship with a physician when
Hmm.
patients are on hospice, there are people who want that, and so I get to be supportive and bring my team in to layer on top of the hospice. Um, And I refer to hospice on a regular basis uh, because there are times when what the patients and families need is beyond what either we can provide or we can help make the whole process more affordable by bringing in other resources that are covered by insurance. So,
Hmm.
yeah,
So,
so especially when patients, need equipment or it's helpful to facilitate getting the medications, and of course the whole end of life when people die, it's always easier for people to die on hospice than not on hospice.
mhm. So it definitely sounds like you have the flexibility, as you said, to fill in the gaps, and you're very good at evaluating those gaps and recognizing them, and then offering whatever is needed at the time. And that's definitely, I would say, that what I found most frustrating in hospice care in a Medicare certified hospice were just the regulations that we have to follow, and the fact that
Mm-hmm.
those regulations did create gaps, and there were times when we had to discharge patients, and it was devastating to us and to the family also that patients needed to
Mm-hmm.
be discharged or we'd be accused of Medicare fraud. And so it must be wonderful for the hospice to have your services as a resource as well, so that they can bridge those gaps and not feel like they're leaving patients and their families stranded at times.
Yeah. Yep, that's been another nice um, sort of niche I would that to help. And of course, the problem with all of this is, I'm sure everybody who's listening or many people who are listening, will identify right off the bat, is it's concierge, right? It's a service that is not covered by insurance, and so there's a resistance in general for people um, to pay for healthcare services that aren't covered by their insurance. Um, and so we have to work with that understanding and help people see where the value is
Hmm.
for paying for something outside of that model. But we also, I just wanted to mention, we don't have to spend too much time, but we created a foundation. It's called the Integrated Life Care Foundation, and right now we're waiting to get the nonprofit status, the 501c3 status, so that donations are tax deductible. The goal of it is to be able to offer a lot of education and support services through the foundation, but also to be able to provide care for people who don't have the funds to pay for it. So we want that not to be a barrier. We want to have people who can pay for it. People who can't pay for it can access funds through the foundation, and then we still utilize all of the services that Medicare and insurance do pay for within the complement of things that are that we're kind of putting in place and sort of orchestrating, um, and making sure that everybody's working on the same page with being communicated with for the benefit of the patient and family.
Mm. Oh, I
So
really
more on
love
that foundation
that.
layer.
Yeah, I love that you found a way to kind of evolve the concierge model beyond only caring for patients who can afford to pay for it out of pocket, and that you have a vision for how you might be able to offer care on a to a broader spectrum of patients. So that's really beautiful.
Yeah, I'm excited about that. I'm kind of chomping at the bit, checking with the IRS every day to see where we are. So because I know there are people who are kind of waiting in the wings, ready to start supporting us.
Well, that's wonderful to hear. Well, I wanted to get into another topic with you, and you alluded to it also, is that many patients do come to you to use the aid in dying law, which California passed. And so I really wanted to talk about that with you, and what that experience has been like. And I know before we started recording, we talked about the fact that I live in Colorado, which also passed the medical aid in dying law, but there are not very many physicians here at this time who are willing to do the prescribing. And so I wanted to hear a little bit more about where you are in California and if you're facing that same obstacle there.
Yeah. So that's been an interesting, journey. The whole being involved in supporting patients through physician aid in dying. It wasn't on my radar when I started my practice a couple years ago. The physician aid in dying wasn't legal in California. The law had actually, right around the time I started started seeing patients, which was probably October, November of 2015. The law had just been signed by Governor Brown, but there was no date set for when it would come into effect. It was sometime in the future. And so I didn't really give it a whole lot of thought. I anticipated that when it when it went into effect, that I would probably have some patients here and there that would be interested in utilizing it. And I anticipated that other physicians would have patients that were coming to them and that they would do what they needed to do to help their patients. But right around, so the law passed in California June 9th of 2016, and like in the week or two before it actually went into effect, I started getting phone calls from a few patients who were anxious. They'd been waiting and watching, and they had terminal conditions that would qualify them to receive that support, but they were not finding any physicians who would support them. I had one patient, there was one lady in her 60s with ALS, Lou Gehrig's disease, she was losing her ability to function very rapidly, much more so than most patients with ALS, and then other neurologic conditions. And people were waiting, like ready to move as soon as that day came, but they were panicking because they couldn't find anyone to help them. So I met with a couple of patients and learned what they were dealing with and going through, and I just couldn't walk away. I decided I wanted to be helping them and get through the process that was now their legal right. So I learned what I needed to, and I developed a relationship with these folks, and realized that it was an incredible gift to be able to support a patient and help them understand what needed to happen to engage with their family and help them see all the different sides of this and eventually come around to being supportive. And so I helped those first few patients out, and then more and more people started coming to me to look for that support, and other physicians in the community started to recognize that I was available to do that, and I think it was really important that I didn't just like do the process. I didn't just do the minimum requirements, I really became very involved with the patients and their families, and had my staff get involved and provide a, a pretty intensive amount of time and energy, making sure that everyone was comfortable, making sure that they knew they could reach us anytime, day or night, and that we were going to be there to help see this through. I made it a point of being available to be with the patients and the families when they took the medication and ended their lives, so I could provide emotional support and just kind of be there to help them understand what was happening and what was normal, or when there was a reason to be concerned. And so it's been a pretty amazing experience for me. I've now been with several dozen patients who have taken the medication and ended their lives. There's others who are in the process, and there's some who have the prescription available and haven't chosen to fill it at this point. But I think that assisting people in getting that through this process and being able to get back the control that they have lost, and feel the comfort of knowing that they can avoid some of the struggle that comes with the final days or weeks of a terminal illness has been probably some of the most meaningful work that I've done in my 30 plus years as a physician. So
wow, it's really inspiring for me to hear that from you, because I myself have done a lot of soul searching about this issue now that it's legal here in Colorado where I live. And I guess until I heard you describe how you are handling this, in my imagination, I thought, if I were to offer this, patients I've never met before and know nothing about would come to me for a prescription, which I might write and hand to them and never see them again, and never know if they used it or not, or never know the outcome. And that felt horrible to me. The thought of that seemed awful to me. I just thought, I cannot be involved in that. But to hear how you've handled it, that you get to know the patient and their families really well, and you spend time with them in advance and make sure you answer their questions and that they understand and are all in agreement, and that you attend the death, that's really beautiful. That really it's really something I hadn't even imagined. And I would think there are probably other doctors out there too who hadn't envisioned that you could be a part of something that's really beautiful, rather than see yourself as just someone called upon to write a prescription and never really engage with that process.
Yeah. Well, and I couldn't imagine doing it any other way. I couldn't do it any other way. I couldn't kind of make it just a transaction. I think that would be inappropriate. And the law is a little bit vague about what the attending physician, what the definition is. And I think ideally, the attending physician for somebody going through aid in dying is someone who's known the patient, has developed a relationship with them over time, and isn't somebody who's just sort of come into their life. But if that was the only way that we could do this, the vast majority of patients who are looking for support would never be able to do it, because their attending physicians will have nothing to do with it. And we can talk a little bit about why that is. But just from a personal standpoint, I do soul searching every day about this, because I recognize that it's controversial from a societal standpoint. It's heavy. And I don't have to do it, right? It doesn't. I make a choice every day to be putting myself in this position, but having seen what I've seen, and having been part of these of these experiences and been with these patients and families as they're in their final moments, it's such a gift to be able to offer to the patients, and it's such an important time to be able to support these families. Because what I realize is these patients are dying, right? Every one of them is terminal. They can't access this or go through this process unless they are clearly terminal. So they're going to die in a relatively short amount of time. Their loved ones are going to go through that process with them, and they're going to live with it. And the majority of people still have a natural death or a non-aid in dying type death, and it's kind of hit or miss how well that will go based on the condition, the support they get from healthcare teams, the family. There's so many different variables. A lot of time it doesn't go well. A lot of time the families are left with scars, and they go on for the rest of their life feeling regret or guilt, or wish they had done things that they didn't do, or wish they didn't suggest things they did. Through this process, the time and again, I've seen families have the most incredible peace and gratitude that they were able to support their loved one in having what is clearly, from my experience, the most peaceful, self-determined end of life that's possible.
Mm-hmm.
And we follow up with all the families. We have little gatherings for families who have supported loved ones through the aid and dying process. And every time that we have any kind of follow up with them, all they can do is say, "Thank you so much. Thank you for allowing that to happen." And they are universally grateful that they were able to be in a position to create that kind of end of life experience. Mm-hmm. So that's what really drives me, is knowing what we're giving to these families that I don't know how else they can get.
That's really beautiful, and for me to just hear your stories and to know that you've attended many deaths now, and what you've experienced and what you've witnessed, that's reassuring to me. And I say this as a hospice doctor, but who got started in doing end-of-life care after my dad's suicide. And so for me, I've had a really hard time separating the idea of patients who receive aid in dying from my father's suicide. And in my mind, I still associate the pain that I felt after my dad's death with, is the family going to experience what I went through after my dad's death? And I would never want to support that. I wouldn't want to help that kind of devastation to happen for a family. So you've reassured me, and especially the way that you offer this service to people by engaging with the family to make sure that they're clear about it and understand what's going to happen. And I know the Death with Dignity movement has worked really hard to separate suicide from this process so that they don't get confused. It's just that in my own head, they have been confused because of the pain that I experienced. But anyway, you've helped me. You've helped me to see that a lot more clearly.
Well, and that's a natural connection. I hadn't thought about. I knew about your father's suicide, but I hadn't actually thought about how you might make that connection. So I'm glad there was that kind of talking about it this way was helpful. And part of the reason I do what I do was just through my own personal experience. Both of my parents passed away in the last few years, both of them from lung cancer, and I had just started my practice. I had just started doing palliative care in a more formal way when my mom's lung cancer recurred, and so I was able to help facilitate the care that she needed and reduce her struggle, but we couldn't eliminate it, and she still had a pretty difficult, traumatic period of time for at least a few days before she died. My dad was diagnosed with stage 4 lung cancer 8 months later, just out of the blue, and he died in 4 months. But he had an incredibly peaceful, beautiful last couple of days of life, and everything happened pretty quickly. But I wanted. It's really important to me now to give people the best chance of having that beautiful, peaceful death, because I know it's possible. I know it's possible in almost every circumstance, but it doesn't just happen by chance. I think so being in a position to allow that to happen more consistently has been really motivating me. The aid in dying piece, the physician aid in dying, it would be wonderful if it didn't require a specialist to do it, if more people were comfortable with helping their patients through the process. And I'm happy and willing to be a resource for that, and to speak with other physicians and help reassure them of how gentle and peaceful it typically is. But on the other hand, I think we probably do want to maintain some degree of specialization around it, because it really shouldn't just be like we had talked about earlier. It shouldn't just be sit in the office, come in, make the request, come back 15 days later, make another request, and here's your prescription. Go fill it, and good luck. I just feel like there's too much at stake, and the need is too great to really provide a truly high level of support, and not leave these patients and families to try to figure it out on their own. So.
Yeah, I agree with you completely, because I guess that was part of my nightmare scenario, in a way, of looking at all of this, as if just random doctors out there start writing prescriptions, and then patients start coming to them because they've heard that they can get a prescription. And so again, they will be patients the doctors don't know and have never met, and have very little information about their family. That I can see some negative consequences from that. So I agree with you. I think there do need to be doctors who identify themselves as willing to be, as you have become, maybe a specialist in this area, and willing to take on the bigger prospect of knowing the patient and their families and getting more deeply involved. And I was going to ask you if you feel, has this taken a toll on you in any way? Do you feel emotionally that there's a toll, or do you actually feel that it has benefited you to be part of this movement? So
I would say both. I would say it absolutely has benefited me, because it's given me a sense of purpose, a deeper sense of purpose. It's allowed me to be present in circumstances and situations that very few people are privileged to be in, and to me that's very sacred. To be somebody who's trusted, to be with folks in their last moments of life when they're making that transition. I feel like I have people throughout Southern California now who I'm connected with in a very deep way, kind of an extended kind of cosmic family, both the people who have passed on and especially their loved ones who remain. So the benefit is tremendous from that standpoint. The toll is, I don't know. I don't think it's been a significant. There have been a couple of days where I've had two. Actually, there was one 2-day stretch where I had 3 patients that I was with who died in a matter of 2 days, and that was a little intense. and I needed to decompress for a bit, not surprisingly. But I think I guess I feel like I have a reservoir of that I can take a lot of I was an ER doc for 20 years, so
Mhm.
I dealt with a lot of emotion, a lot of trauma, I told many people that their loved one had died, or there was a lot of, I guess I become good, and I'm hopefully not sort of I know some physicians have been accused of, or probably it's very accurate, that they have to be emotionally distance themselves from patients and situations so that they don't get it doesn't cause too much turmoil, and but I find that getting emotionally connected is the best route for me, and
Mhm.
but there is this little bit of danger, just in honesty, where the level of engagement in many scenarios, in most of the scenarios, that not just with aid and dying patients, but with the other patients, it's such a level of intensity, and the conversations are so intense and frank that sometimes I worry that like normal life isn't gonna do it for me, because I'm so often engaged at such an intense level that what I mean, where sometimes
Yeah.
like normal conversations aren't enough to get my attention, but I'm hopefully that's not the case, but I worry sometimes that could happen.
I know exactly what you mean. That once you open yourself, you open your heart and your mind to engage that deeply with people, and then it's hard to be content with more superficial interactions that don't have
There you go.
that depth of meaning and just connection. So yeah, I
Yeah.
understand that totally.
Yeah. And you articulated it better than I did, but that's what it is. But there's beauty in the mundane, right? There's beauty in the normal, just everyday conversations, and so I need to make sure that I continue to appreciate that.
Yeah, absolutely. Um, Well, I wanted to ask just before we run out of time if you have any advice for other physicians, so including me. Let's say I'm a doctor who's wondering, oh my gosh, should I start writing these prescriptions? Knowing here in Colorado, at least, I know there's a huge need. Patients are struggling to find doctors in their area who will write prescriptions, and we have a large Catholic hospital system here throughout the state that does not um, support aid in dying, and so all the physicians who work for that institution cannot be part of
Mhm.
it. So if there are other doctors out there who are considering, should I do this or not, do you have any advice for us of where to start and how do we get ourselves more comfortable with this idea?
So, I guess the first thing that comes to mind is, ideally, if somebody's going to do this, to make it a part of their practice, then you really should be willing to commit all the way. And I don't mean like make it your entire practice, but when you do take a patient through this, that you really need to be um, ready to support the patient and their family, and to have the conversations, and to be available, and a resource, so that because once they start the process, it in their mind, they not every patient who starts the process is ready to get the prescription and wants to take it as soon as they get it, but a significant percentage are, because things are changing for them rapidly.
Mhm.
They're struggling, and a lot of times they're afraid that things are going to progress to the point where they can no longer do this. So timing becomes very important. So I think the first thing is, it shouldn't just become like a little side thing. It really needs to be taken on with a certain level of commitment, and to be available to be there either yourself or to have other support, like a social worker who can step in and offer the additional guidance and support that is needed. And I don't think I would want to do this to make the prescription available to patients without also making myself available. So I think as a physician who's going to support patients, you have to be willing to go all the way. So, and unfortunately, when people are going and working with the Medicare insurance, there isn't really a mechanism to get paid appropriately for the amount of time and energy that it will take.
That's a good point.
And I don't necessarily have it is because you can bill for visits in your office or you can bill for home visits, but often the to do this well, to really fully support patients and families, requires phone calls and emails and then time that may not be able to be reimbursed. So that has to factor in as well. I think that the one thing that anyone who's part of the process should be aware of is how you find the consulting physician, obviously what the requirements are, finding a pharmacy that is supportive of patients, and creating a streamlined process so that things aren't haphazard and you don't end up having delays that could be really distressing for patients and families. One of the great benefits of people working with us is that we start the process and we know exactly how long how long it needs to take. We can make our second visits as soon as the patient is eligible to have that second visit. We streamline with the pharmacy, so they don't feel like they're confident. They're confident that the process is happening because they're still extremely anxious all the way through. They're very anxious up until the time they have the medication in their hand, in many cases. The other, and I think helping people understand the actual process when somebody does get the medication and they take it, what the right steps are to have something that the patients will have access to, so that they feel prepared and the family members feel prepared. There's a lot of places where things could go wrong, and I don't mean like physically wrong when the patient takes medication. It's just within the process, dealing with hospice agencies or dealing with medical examiners or dealing with pharmacies. So I guess the one overarching recommendation would be don't get into it unless you're really willing to commit to supporting in a large way, in a very comprehensive way.
And so I think that does mean, for a while at least, we will probably deal with shortages of physicians willing and able to do this work. That's going to take time, and I hear from a lot of people here in my state who are very frustrated and feel like it's our legal right. We're not getting access. We don't have the support we need. But I think it's a time of transition, and it's going to take a while for us to grow some new doctors who are, who are more open-minded and more ready to take this on and more ready to do what you're doing. And so we're all going to have to be patient through this process.
Yes, and maybe maybe it will be an opportunity for someone like me who has a significant amount of experience and kind of a program that seems to be working well, to do some trainings and to get some physicians who do have an interest in looking at it together, so we can potentially talk about what it would take to get the appropriate education and knowledge base to do it well, then I'm open to that.
That's wonderful. And I didn't mention it before, but I wanted to make sure I mentioned your website, which is drbobUslander.com. And Uslander is spelled Uslander, drbobUslander.com. Would that be the best way for someone to get in touch with you, Bob, if they wanted to talk about this idea with you?
I think so. Yeah. I mean, there's a contact form on the webpage. I'll give my office phone number as well, which is 858-925-7554. And I mean, I'm willing to have a conversation pretty much with anybody about this, because a big part of our mission is to educate people and to be a resource. So whether somebody is interested in learning more about the process, or from the medical community is interested in learning about getting supported or guided, I'm happy to do that.
Oh, that's really wonderful, and I look forward to seeing if you're able to put together some sort of trainings. It's just really nice for me to know when I go around speaking to other physicians that I could refer someone to you to get information.
Yeah. And I'm seeing this as a need. It seems like a growing need, and so I think one of the best ways to provide more support to patients and families is to provide support to the physicians who are in those communities.
Well, this has just been a wonderful conversation, and Dr. Bob, I wanted to say to you, through all the interviews that I do and the writing that I do, I spend a lot of time talking about what's wrong with our medical system and how we approach the end of life. And we've done a lot of analyzing of all the problems and what's wrong, but it's so refreshing to talk to you because you're someone who's actually addressing the problems and the gaps, and you're actually creating a new model, and you're actually doing it by yourself. And I have so much admiration for you. So I just want to thank you for the work you're doing.
Well, thank you, Karen. I appreciate that. I know that you are actually making a big impact around the things that you're passionate about. And like I said, I think you and I are, from the first time I saw you presenting, here in San Diego and introduced myself, I kind of known that we were on a similar path, and I look forward to seeing how our paths continue to, intertwine. So, as I'm sure they will.
Yes, absolutely. Well, thank you for taking time out to be here today, and I'll just share with our listeners that you just barely came from the bedside of someone who was actively dying before our interview, and so you're right in the heart of this work, and your willingness to be open to the conversation is something I'm very appreciative for.
Well, thank you. I think we're part of the Mutual Appreciation Society.
Yeah,
Mutual Admiration Society. So.
Well, I'll just remind everyone listening to go to your website, drbobUslander.com, so they can learn a lot more about your work and also how to get in touch with you. And so, Dr. Bob, until the next time we connect, I'll say goodbye and thank you.
Okay. Thank you, Karen, and thanks everyone for listening in. Take care.
All right. Goodbye.
Bye-bye.